Hi, everybody. Just getting all set up here. Bear with me while I'm just getting our Facebook Live set up. Just give it a few minutes while everybody's kind of logging in here. For everybody that doesn't know me, I'm Michelle Saari, a registered dietitian, and I'm from the Long-Term Care RD. You can find my website at www.longtermcarerd.com. You can also find me on Facebook at Long-Term Care RD. If you're tuning in here, please feel free to drop comments throughout the video. You can comment, let me know where you guys are from, where you're joining me. Love to hear from you guys, but I'll just give it a couple minutes here while people are kind of logging on still. So please drop comments, questions. I'm happy to be here joining Build Up Dietitians today. So thanks to them for inviting me. I'm very fortunate that I get to talk to you guys today. Okay, so we'll just give it a few more minutes and then I'll get started. Welcome to everybody who's tuning in right now. Hi, Leah. Thanks for having me today. So like I said, you guys can find me at Long-Term Care RD on Facebook. You can also find me at www.longtermcarerd.com. I love connecting with other dietitians, so please feel free to drop me a comment, an email, a message. I'm always happy to work with other dietitians. Get started pretty soon here. Today I'm going to be largely focusing on COVID in long-term care. It's definitely applicable to all aspects of clinical care, acute care, home care, simply because COVID is affecting every area of healthcare right now. Whether you've dealt with it or whether you have had it yourself, it's amazing how fast the Omicron is spreading. I myself just recently got over it and it was not a fun experience. So wear your PPE at work. That's my biggest recommendation right now. Okay, so we're going to get started pretty soon. Okay, so maybe we'll just get started. So my name is Michelle Saari. I'm a practicing registered dietitian in Manitoba in Canada. It's 11 a.m. here, so it's cold, blustery days, so I'm happy to be inside doing this Facebook Live with you guys. If you can't hear me or if there's any fuzziness, please just drop me a comment in the comment section so that I can work with you guys. So what we're going to be talking about today is largely COVID in long-term care. But like I've said before, it's, sorry, I'm just reading your comment, the event for this. Okay, so we'll try to share this to other pages here, just so everybody can see it. Okay, so like I was talking about, I'm just reading through comments as they're coming in, so I'll try to get to everybody's comment as I'm reading this. So what I want to talk about though is clinical nutrition care with COVID. The practice guidelines have changed quite a bit as new research is coming out, as new information is coming out, and I know dietitians especially are just we're being stretched thin. You know, we're short-staffed in the nutrition and food services department. So a lot of dietitians, especially if you're logging onto these Facebook pages and you're seeing the comments, they're being pulled into the kitchen. They're being pulled to do feeding assistance at meals. And it's really spreading them thin where they can't manage the clinical workload because they're being pulled to other aspects of care. My best advice to dietitians in that area is that we need to be as patient as we can with our nursing homes and long-term care homes, but we also have to balance this with not being taken advantage of. And I don't think a lot of nursing homes are trying to take advantage of staff. They're short-staffed, they're trying to get by. But for myself, I know that I've had to draw a line in the sand that if we're struggling for a couple months with not getting enough staff, it's time to start hiring more casual staff. This can be just a polite conversation that you have with the nutrition manager, your administrator, your director of care, your CEO, whoever it is that you go to with issues. I highly recommend that if you're feeling like your clinical care is suffering because of this, then I really think that you should go to them and talk to them about the hiring process of diet aides. The clinical nutrition care is of the utmost importance in COVID patients and post-COVID patients. The recovery is, the research out there is staggering that if there's malnutrition involved with COVID care, then we're going to run into a lot of issues. A lot of the interventions that the nurses, the doctors, whoever else is involved, if they're working with a malnourished patient. And we already know that 35 up to 85% of patients that enter long-term care have malnutrition already. And the numbers vary so much. That's obviously a 50% gap because everybody uses different measurement tools to assess for malnutrition. It would be great if we could standardize that in long-term care, but there's a bit of a struggle with that. So I highly recommend that in your facility, you standardize how you're assessing for malnutrition and how you're diagnosing. If you don't have a standardized tool, I recommend the SGA, the Subjective Global Assessment Tool. It's a validated tool where you can assess for malnutrition. If you're looking for more information on how to diagnose malnutrition, you can log on to my website, longtermcarerd.com. I have a free blog, I have free SGA, I have free mini nutrition assessment forms that you can use on there in the resources section. So feel free to log on if you're wondering, how do I diagnose malnutrition? Go on there and I educate you exactly on the steps you take, how to chart on it, how to use your PES statements, all of that information. That's a little bit of a side note though from talking about COVID. So like I said, if you feel like your clinical care is really suffering and you're not able to do initial assessments, annual assessments, quarterly MDS, talk to your administrator that you can't be pulled into the kitchen every day. That's not why you were hired. There's nothing wrong with helping out the team because everybody has to help out during COVID, but the clinical nutrition care of patients should be number one priority. So talk to them in a respectful way that you need to get out of the kitchen. You need to get with your patients. Next, I want to talk about what are the practice guidelines. So I've seen from a number of dietitians that they talk about vitamin and mineral supplementation in COVID, post-COVID patients. So the research just doesn't support it quite yet, unfortunately. I think the recommendations are generally you should be focusing on hydration and food first. If you need to use oral nutritional supplements, so Resource 2.0, Boost, Ensure, whatever your facility is really using, I highly recommend implementing those. So what you want to do though is, I've seen that some docs are not supportive when dietitians are recommending vitamin supplements. Don't fight that battle right now simply because the research is just not there yet. At least research that I've looked at, my regional health authority, we don't recommend vitamin supplement unless we know there's a deficiency. I don't recommend asking for blood tests for something like vitamin E, anything like that. These patients post-COVID have already gone through enough invasive procedures to treat them for COVID that the last thing they need to do is unnecessary blood tests when the research doesn't support it. So you're going to want to be aiming for about 25 to 30 calories per kilogram in your patients and 1.5 grams per kilogram of protein in their diet. Typically 1.5 grams, yes, it's high, but chances are your post-COVID patients have protein energy malnutrition. They have probably advanced sarcopenia, depending how long they were recovering from. So you want to start correcting those along the way. Most of our patients do have some level of sarcopenia and it's age-related. So you're going to want to start correcting those things along the way. A high protein, high energy diet, we have them in long-term care. You probably know, you probably administer them. So I recommend that right when your patient is post-COVID and you can go assess them, go assess them. I did write that you should not be assessing all of your COVID patients when they're positive. A lot of reasons behind this. So, in my experience, most of my patients have recovered from COVID within about 2 weeks. So, you need to install a protocol at your workplace on how they're going to get in touch with you if you desperately need to see a COVID patient. Dietitians, unlike a lot of the other professions in the long term care home, um, they travel throughout the entire building. And so the risk of you as the dietitian spreading COVID from one unit to the next is very high. Unintentionally, obviously, the number one thing we want to do is protect our patients and keep them safe. So unless you have to be on a COVID unit and you have urgent consults, don't go to that unit. You don't want to be the reason that that COVID spreads from place to place in your building. So you can do virtual consults if your workplace has that ability to do so. Many therapeutic recreation departments will have iPads now, which is awesome. And you can borrow these and use them on the units if you need to be assessing a patient or doing a meal observation, something like that. So super important that you take the patient's safety seriously when it comes to COVID. I know it's really hard not going to visit your patients when you know that they have COVID, but they need to rest, they need to recover, they need to have as little outside contact spreading germs to them. And so you can get the nurses, you can get the healthcare aides, phone you anytime when you're in the building. If they have any questions about their nutrition care, you're available. Just in-person visits, you should probably limit a little bit. And then once the negative test comes back, that's where you would get involved. So that's where you would go, you would reassess your patient. I like to do a full nutrition assessment once I know that my patient is COVID negative at that point. So this typically will look like your initial nutrition assessment form, for lack of a better term. I redo an entire assessment on them. So I want to know, how has their oral intake changed? If we can get a weight, I know a lot of nursing homes and long-term care homes have put weighing the patients on hold, but it's a valuable piece of information. So if there's any way possible that you can get that weight, I would really try to ask if even you can be involved and help to get the weight of the patient. If they're upwardly mobile, if they're going to the dining room, do you have a floor scale that you can use? So you want to do a full nutrition assessment because you're going to be looking some of these patients based on fatigue that's been developed through COVID. A lot of patients are experiencing GI symptoms. So they might have had bouts of diarrhea, they might have had a fever, so excess sweating, which can lead to dehydration. These are the things you're going to want to be looking at. And there is dysphagia concerns coming from some post-COVID patients, especially if they've had to be intubated. So you're going to want to do a meal observation screen as well, where you're going to watch them eat. You're going to be doing a swallowing assessment. If you need to get your SLP involved because you do think there's some level of dysphagia, I definitely recommend sending that consult out. The SLPs are just the most phenomenal allied health professionals, in my opinion. I've had fantastic experience, and even through COVID, whenever I've had a consult, they've been great with coming on board and trying to help get that patient's nutrition care back to an optimal level. So you want to focus, though, once you've done your full nutrition assessment, you want to work with the other professionals in your healthcare team. You're going to want to look at, how can we improve? Do they need more eating assistance? Because if they've gotten weaker, if they have more fatigue, if they've lost weight and muscle mass, they might need some level of eating assistance. So you're going to be working with your healthcare aides as well as your nurses to develop essentially kind of a new care plan. Care planning with post-COVID patients is really important. Depending how your facility does your MDSs, do you need to recode your patient's new status? So work with your team. It's really important because you're all working together to get the best care for that patient and getting them back to a baseline that you can have them stable nutritionally. I recommend also that every single post-COVID patient, you're placing them on your high-risk tracker. You might have this in some other phrasing or words. Whatever you consider your high risk patients, I would develop a list and I would keep all your COVID patients on there until your diagnosis of malnutrition is gone or you've corrected their nutrition to an optimal level where you think, okay, now they're stable. So really keep track of those patients, and you're going to want to follow up with them every 1 week, maybe stretch it to 2 weeks if they're a little more stable. You're going to want to keep following up with them until you feel like you can discharge them from your high risk tracking and just put them back to their normal quarterly, annual assessments, however often you're tracking your patients. So the one thing you're going to want to watch for is dialysis patients or those with impaired renal function. I've had some dialysis patients where just due to COVID risks, they're not sending them for dialysis quite as often, and we're trying to manage them in long-term care a little more. So with those patients, make sure that you're going slow and steady with your incremental rises in the protein, just to see how they're managing. Chances are you're probably doing blood tests a little more often in those patients simply because they're not going for dialysis as often. So even though rehydration is really important in post-COVID patients, make sure that you're tracking them with their fluid intake as well as their protein intake. You're going to want to balance, be checking for edema. I'm sure the doctor is going to be really involved in these types of patients. So in the comments section, Leah, you're absolutely right. I also see a lot of facilities that are dumping, as you know, you phrased it, vitamin and mineral supplements. It's just like in the regular population a little bit, is that we're highly recommending vitamin and mineral supplements, but the research just doesn't support it. So don't go out on a limb and fight with a doctor about recommending vitamin and mineral supplementation. As a dietitian, you really want to be up on the latest research, especially with treating your COVID patients, because it's not a large population right now. I think in my facility, there's probably only about 5% of the patients that have COVID, thank goodness. You don't want to go out on a limb and be pushing for vitamin and mineral supplements that they don't need. You want to reduce the amount of pills that they have to take as best you can. Swallowing issues, patients generally don't like swallowing a ton of pills, and a lot of multivitamins and vitamin and mineral supplements, they're gigantic and they're hard to swallow. So try to focus on getting their vitamin and minerals from a varied diet. So I really recommend just reevaluating, check the research, check the latest policies in your region. A lot of regions were really great at putting out post-COVID nutrition information, and so policies, procedures, that type of thing. I've been fortunate that my facility put out really great resources for that, so it gives you guidelines. I'm going to have a blog out next week actually on treating post-COVID patients, so you'll be able to find that at Long-Term Care RD, and I'm going to be going into detail about what are the actual recommendations, not what are we concerned about, because they will have some vitamin and mineral they won't fall to a level of deficiencies likely, but they will be lacking. If you have a patient that isn't eating much, or they might be intubated, or losing weight, then yeah, you're going to be concerned about that type of thing, but try to restore it through a food first approach. You can supplement this with oral nutritional supplements. I know some facilities are actually doing Gatorade as well, which is really interesting to me. High priced item, but well worth it in your post-COVID patients just to restore some fluids and that type of thing. But work in conjunction with your doctor. If you do find new research though, you should present it to the doctor. But in my experience so far working with COVID patients, I haven't seen the research supporting that. So I would just recommend make sure you're up to date on research. Just because we're dietitians doesn't mean we need to be fighting for vitamin supplements that aren't really necessary at this point. So yeah, so if you guys have any questions about post-COVID patient recovery, please feel free to drop them in the comment section. I'll answer questions as I kind of go through this. So Yeah, I'm just reading through some of the comments here actually. Um, they also have, back to malnutrition a little bit, Aspen has some great resources out there. Um, just a little bit of a side note. So I actually worked on, for my master's thesis, this really great project. It was the largest long-term care study of its kind in long-term care, which I just said. It was across 4 provinces in Canada, and we had, I think, 639 residents in total. So we had a super diverse group of people that we assessed, and it was called the Making the Most of Mealtime Study, or the M3 project. I highly recommend that you Google this when we get off of this awesome Facebook Live video. Um, it's leading research in what affects food and fluid intake in long-term care. And the value that you can take away from this type of research is really great. So we talked about eating assistance. My project was specifically focused on food service satisfaction in long-term care, and how there is strong associations between food service satisfaction and malnutrition rates. So there's so many different aspects of resident care that affect malnutrition and that are associated with it. So look up Making the Most of Mealtime Study. We have a lot of papers released, research out there. There's a lot of just practical knowledge. And if you're looking to strengthen your argument to get more hours in your long-term care facility because you don't feel like you can cover all of your bases with it, then the research is out there that can confirm that when a patient has malnutrition, it's a domino effect with so many other things. Um, so you can strengthen your argument about getting more hours in long-term care if you have the research to back it up. On my website, Long-Term Care RD, I actually have a free template that is a proposal letter for administrators in long-term care facilities on why you need to work more. So if you feel like you can't get your clinical work done in the time, don't let the patient suffer. Advocate to get more hours. It's not the easiest thing, and I'm not saying that you're going to present the hospital stay length. It increases risk of falls and fracture. It increases the risk of early mortality. You can have a really strong argument as a dietitian about how vital you are to the team, how if you can correct malnutrition, that their overall health will be better off for it. Um, you will be able to get more hours in long-term care. I've done it before. I wouldn't recommend something that I haven't actually tried and been successful at. So go onto the website. Feel free to take the letter, alter it, because you're going to want to put in your long-term care facility's name, add in specific details, your EFT, things like that. So I really think that dietitians should be in a long-term care facility on a full-time basis. 5 days a week, there should be a dietitian there at all times. So if you feel like you want more hours, then please go ahead and use my template. I'm happy to push. So Sarah, yes, I read the comment. I will. So I'll just let you guys know. The research article that I was talking about is Making the Most of Mealtimes, or the M3 study. There you go. So the lead researcher there was Heather Keller. She was based in Waterloo, Ontario, in the Institute on Aging. She is a fantastic long-term care researcher, and she's just put out so much stuff advocating for dietitians in long-term care. And there actually is, in the M3 study, they did find associations between the amount of dietitian hours in a facility per week, and they correlated it with food, energy intake, protein intake, things like that. So again, another awesome thing that you guys can use. If you want specifics though on which papers were had those numbers in them, because the M3 Making the Most Mealtimes project, it put out I think 15, 20 research articles so far. If you want to know the specific ones that those are in, please reach out to me. You can find me on Facebook at Long-Term Care RD, and longtermcarerd.com is my website. I can send you those specific articles because I do have them on hand. So if you also look up the Making the Most of Mealtime study on the Research and Institute on Aging, on their website, they have just summaries of exactly the research that was found. their malnutrition rate that they found across the 4 provinces in 32 nursing homes was 44% are malnourished, and that might be a drastic undercount. Just based on the fact that some dietitians still don't feel comfortable diagnosing malnutrition, and some dietitians simply don't document it or chart it. So that's why I really recommend that as dietitians, you become educated and comfortable with diagnosing malnutrition, because it is within your scope of practice. So I really recommend that if you're not at that level where you think you can diagnose malnutrition, go onto my website and go through the education, totally free for you guys to do, just on how to diagnose malnutrition. A lot of dietitians will use the standardized nutrition terminology for their PES statements. So they might write that the resident has inadequate intake or unintentional weight loss, things like that. If you do have 2 or 3 different diagnoses that you look at your patient and you think, I could diagnose this patient with unintentional weight loss, inadequate energy intake, then you have a malnourished patient right there. So it's really important that you get comfortable. Christina asked, is there sample documentation templates for diagnosing malnutrition? Yes. So the way you can diagnose malnutrition is through an SGA or subjective global assessment. I do have them for free on my website in the resources section. And if you just Google subjective global assessment, you will get a lot of returns on your Google searches. I will try to post actually on my long-term care RD Facebook page so that you guys can see it. So there is standardized ways that you can diagnose malnutrition. So what I recommend though is that you learn that skill. If you go through the SGA assessment, it's going to look at weight loss over a significant period of time. So between 1 and 6 months, it'll be between 5 and 10%. You're going to look at energy intake. You're going to look at their physical status. You're going to look at factors that are affecting their nutrition intake. So dysphagia, dental problems, anorexia, things along those lines. And at the end of the SGA, you can rate them as A, B, or C. So A, B, and C, from those, you're going to get a malnutrition rating. A is well nourished, or normal nutrition status, as I like to say, because I'm not sure we would call a lot of our patients in long-term care well nourished, but baseline essentially. B is there is some level of malnutrition or they're at risk for malnutrition. And then C, you're going to diagnose them as having malnutrition. So based on your SGA assessment, at the end of your SGA, you're going to find that you can give them an SGA rating, which will diagnose them with malnutrition or not. So you can find all of this on my website, longtermcarerd.com, but I will post it on my Facebook page today, Long-Term Care RD, you can find me at. And I'll give you those links to how to diagnose malnutrition. And then I know in the States there is incentive to diagnose malnutrition, which I find very peculiar to have incentive to diagnose for malnutrition. But so there will be some reimbursement for your facility for diagnosing this malnutrition. And I hope that some of that money goes to patient care. I'm not familiar with how the budgeting works out there. In Canada, we don't have the same incentives. There's not reimbursement for a diagnosis of malnutrition, so we're not incentivized to do it. We just diagnose with malnutrition because that's what we see. So if you would like more education on diagnosing malnutrition, I will post more information about that, because I think it is awesome when dietitians go within their scope of practice and learn new education, learn new skills. And I also think your patient really benefits from you accurately diagnosing them, because once you diagnose them with something, then you can look at what type of interventions can we do to correct this malnutrition. We know they have it now. Let's move towards intervention, set goals for them, and then let's do a monitoring and evaluation plan. So all dietitians, you've been trained throughout your training on the nutrition care process, which takes you from diagnosis to monitoring and evaluation. So if you're not comfortable with that, there's lots of great tools out there. You can find them online. I probably won't tout too many different places because everybody has different likes. I try to centralize all this information though on my website and my blogs that are free for all dietitians. I have a real strong passion for educating dietitians, and my website was really just a hobby when I was on maternity leave because I missed working with dietitians. I missed educating interns. I missed all that kind of stuff. And I think as long-term care dietitians and perhaps in acute care facilities, on home care teams, you might feel alone in your practice. You might not know where to turn. But I really recommend reaching out to a community of dietitians. The Build Up Dietitians website, especially the niche ones, you can find such a great community of dietitians there. So reach out. There's so many dietitians that want to help you, myself included. So if you want more information on anything that I've talked about today, you can find me on my website at longtermcarerd.com. You can also find me on Facebook at longtermcarerd. I'm Michelle Saari, and I was super happy to be here with you guys today. I hope you found my information helpful. If you have any questions, please feel free to ask. I'm happy to answer them. But thank you to Build Up Dietitians and Leah and Andrew for inviting me here today. It was a great pleasure to work with Build Up Dietitians. I strongly advocate like and follow their Facebook page if you want to find a niche market because you're practicing in long-term care, gastro, wherever it may be, diabetes. Build Up Dietitians has some really great niche Facebook pages, and I found it super useful. I found a great community of dietitians there too. So find me on my website at longtermcarerd.com, and you can also find me on Facebook at longtermcarerd. So that's the end of our chat today. So thank you to everybody, and I hope to connect with you guys all again soon. Okay,